Good morning, everybody, and welcome to this first knowledge exchange webinar between the Basque Country and OptiMedis. For those of you who don't know me, I'm Andrea Pavlikova, and I have a pleasure to coordinate Scirocco exchange project. And so within this project, we are currently running the knowledge transfer program for over a year, where we give the opportunity to our partners to learn from each other, from their experience in the area of integrated care. And particularly today, we are focusing on implementation of electronic health records in the Basque Country. So this is our first knowledge exchange workshop. And really the idea here is to provide some introductory information to the questions which were posed by the OptiMedis and learn from the experience of the Basque Country so far. And hopefully at the end of the workshop, we also will be able to identify potentially some topics for further knowledge exchange activities. So really, this is the opportunity for you to ask the question, learn from each other, exchange the experience, and then, let's have at the end have a discussion about the next steps for this mutual learning. So without further ado, we have, in terms of the structure, we have 3 presentations from our colleagues in the Basque Country, and then I believe we have almost more than 45 minutes for the discussion, questions, and as Nessa said, we'll use chat to capture the questions as we go, but then we will have the live discussion after the presentation. So we'll kick off with the first presentation from Mikel, who will give us the background information on the implementation of electronic health records. So I'll hand over to Mikel.
Hola, muchas gracias, Andrea. Soy Mikel Ogueta y os voy a presentar la historia clínica electrónica. Voy a intentar compartir ahora la pantalla. A ver. ¿Se ve la presentación?
Can you see my presentation?
Sí, ¿no? Vale.
Yes. Fine. I'm going to be talking today about the electronic health record, which we call OSABIDE Global. Mikel, I'm afraid we can't see your presentation. Can you see it now?
We can see only your Explorer window.
No.
Yeah.
Maybe you need to open your presentation first and then share it.
You have to share your screen, not the Explorer windows.
¿Vale?
Ahora sí.
¿Ahora?
Ahora sí, Mikel, ahora sí se ve.
We can see it now, Mikel.
Vale. Bueno, pues lo que estaba comentando.
As I was saying,
Voy a presentar la historia clínica electrónica de Osakidetza, que es
I'm going to tell you about the the electronic health record that we call OSABIDE Global in Osakidetza. We're going to be talking about our patient radar, and the ebook, the timeline, electronic prescription, and non-face-to-face consultations. In our system, people are at the core of the system. This is easily said, but not that easily done. And they are looked after by our professional clinicians. And we work in a system called OSABIDE Global. What are the requirements of this new model? Well, we had to carry out some administration changes. We had to adapt our system. We also needed to bring about some changes in terms of IT. And then there was a cultural shift, which, as you may know, in some occasions, this is the hardest part of all. Some information about the Basque Country. There's a population of 2 million, and we have the population classified in the electronic health record. In order to follow up our patients, we have this tool called patient radar in order to know what is going on in a more proactive way. And for that, in our clinical dashboard that you see here, we have, for instance, pending tasks here concerning medication, the results of tests that have been carried out, etc., etc. So this way we can follow up what is happening with our patient. On the other hand, we also provide information about the situation of the patient. So we can know in real time what are the patients that are in hospital, what diagnosis they've received, and we can look at their health record directly in order to know what's being done. In each case, you can see that here. We can have that information online in real time. On the other hand, we can also know what patients have been discharged by the emergency service. This is something we see here. Or we can also get information about what patients have had COVID and what their evolution is, if they are in hospital or not. We get all this information, and on top of that, we also get information about patients that are included in clinical programs. For instance, patients that are in a specific program, multi-disease patients, for instance. So Osavide Global is made up by a number of different elements like ebook, timeline, and electronic prescription. And with all these tools, we can provide non-face-to-face consultation, also face-to-face, of course, and we can access information and provide information that then our patients can get by looking at their health folder in a very simple and easy way. The main key of the process is the continuity of care, and the strategic lines here are mainly that we have one single image. We network, we work and provide face-to-face and non-face-to-face consultations, and we have all that information available in a single channel. And this system is also sustainable. That's also essential. We have developed this health record that you see here that facilitates integration of all the different elements of the system. Who can have access to all this and how? Well, confidentiality is paramount for us. So we need to define very clearly and carefully who can have access to a health record, from where. It could be from one single place or from many different places. What information they're going to be able to access. That is something we can also limit. And on top of that, we can also define the different gadgets that we want to activate, the tools we're going to be able to use. As for what patients we can get information from, well, only the patients that have an activity in the area covered by our hospital or health center. The main change over time lately is that we have a super specialization that's been going on. We see these Da Vinci robots that we also have in the Basque country. So we've concentrated very much on specialization, and sometimes we forgot that general vision of things that is very necessary for any integration process. And when we place our focus on one single and specific thing, of course, we get a very accurate picture of things. Nevertheless, when you zoom out and place ourselves in the shoes of the patient, if we don't have a global vision of the process, then the picture is not that good as could be expected. So this is why there's been a necessary mindset change here, so that we can work together at all levels with a common objective. So for us, at first, the main goal would be networking, but now what we actually realize is that networking needs to be applied everywhere in our system, not just on health record. It needs to be possible in radiology, for instance, in the e-prescription system we have, and in the system we have for laboratories, because we understand that networking is essential and makes the most of the collective knowledge we have. And for that, we need to be able to share information in an automatic way so that we can provide the best possible care to our patients. So electronic health record places the individual at the core of care. We have, on the one hand, non-face-to-face care, and on the other hand, face-to-face care, which is the most traditional one. We have included here, for instance, nursing home care, private hospitals as well. 100% of Osakidetza, both in terms of primary attention and hospital care, are already integrated in this electronic health record system. 100% of the pharmacies in the Basque Country are also integrated. We already have more than 300 nursing homes that are connected to this electronic health record system. And we also have some private hospitals included. But the picture wouldn't be complete if we could only or if we only concentrated on Basque Country. And this is why we also have a connection with the electronic health record of the National Health Service in Spain. So each region in Spain provides a summarized health record, so that if that patient travels to a different region in Spain, that information is available in the system. We're also participating in the European Patient Summary, so that that summarized health record can be shared with the whole of Europe. And we therefore are now translating summarized health records into English, so that that information is also available in English at a European level, so that patients can have the necessary care in Europe. So what's very clear here is that integration is not just an addition of different elements. We tend to mix these two concepts, but imagine we have this picture, which looks like a puzzle. When you finally finish that puzzle, you may see that the picture is just an addition of different elements, not what we should expect. But if we add to that an integration process, then yes, we get the picture that we expected. OSABIDE Global is an electronic health record system, but we're also fully aware of the fact that there may be a number of different requirements there. So we have a health record, but it can be shown in different ways so that it is adapted to the different needs. And for that, for instance, we can get information about the hospitalized patients, where we see a number of different alerts that are given to us. And that's something we see automatically here on the screen. We can also get information about the evolution of a patient without actually going into the whole health record record, sorry. And so it's something very easy. You just have a look at the latest evolution of the patient. You don't necessarily have to go through the whole record. For instance, in home hospitalization, we've got information about the actual address, so we can go there if we need to. So as we said, this electronic health record is a working station with a number of different functionalities and programs that we have up and running in OptiMedis. It integrates, for instance, cardiology, laboratories, and then we've recently changed our lab program, but the new program was very easily integrated into the system. It was a single integration, and we didn't have to actually integrate the whole thing.
Sorry, I was on the wrong channel. So we have a huge amount of information in the OptiMedis business intelligence system, which can come up with automated scoreboards and can give you the information that you need about the patient at any particular time. This is what the patient view. This is the most important part of the common area, regardless of what specialist area you're working in. And as you can see, it has a number of different functions, and the clinician can reorder different functions, or they can activate it or deactivate it in order to adapt the whole program to the needs of the patient and the care that's going to be provided for that patient. When we're talking about continuity of care, it's important, for example, if we have a patient who has been admitted from the accident and emergency room, we have to know what the problem is exactly. So we have access to the accident and emergency room report straight away. And if that same patient who's been referred to a different clinician, we can see the reason for this referral and why a fellow clinician has decided to refer us this patient. So we can ensure good continuity of care throughout the entire process. Another important part of this is that we include everything that has been prescribed or done with that patient, or the tests that have been carried out for them, no matter who asked for it, no matter who did it. The aim of this is to avoid duplication of tests, which is something that's happened a lot and is completely inefficient. We can see all of the different tests. Even if you haven't asked for them, if another fellow clinician or another hospital even asked for them, you can still see the results of these tests, which will enable us to optimize the use of health resources in relation to this patient. If we look at diagnosis, we've gone from this, which what we can see here on the left-hand side, we had the diagnosis written by hand. Now we're using artificial intelligence systems with the natural language processing systems. The program codes what is written. So if a clinician writes a text or a diagnosis with natural language, it can be automatically translated into a CIE10 code. But it's obvious that within the electronic health records, there is nothing that has a more obvious chronological timeline than the care provided to a patient. So it's very important to actually have a chronological record of this. So we've created a patient ebook. So it's a book that's specific to any patient, where every single clinician who intervenes with that patient writes what they've been done. So we all share the same document, and there we can see that everything is registered. It's grouped into the different services that the patient has been seen by, and there's also a chronological timeline, etc. But any clinician who is going to be caring for this patient will need to register everything that they do on this same platform, in this common platform, which is what we call the ebook. And then you can carry out searches, you can apply filters, you can search for key terms. There are a number of other tools as well, which simplify the search for information about the patient. So to facilitate a registry of this information, we have enabled this function. You can actually copy and paste and drag information from different parts of the electronic health records in order to, so that we can explain why we're making certain decisions. And we can also dictate the text, and then that will automatically get changed into text. So we can actually dictate it, and the text will appear on the screen to make life even easier. Another characteristic of the ebook is that as well, you can actually write text. You can also incorporate different links to different places. So you can include structured information within the electronic health record. And we can do that directly in the ebook, or we can add images or photos, which are representative, for example, and are important, and we believe are important to charting the evolution of the patient. So we have this huge amount of information that we're generating. We're talking about 2 million. We have a population of 2 million, and we're using this in about 28,000 of them every year. What we need is a kind of a graphic overview of it to enable us to visualize what's happening much more immediately and in a much more global and holistic manner. So there's an automatic online representation of everything that's included in the electronic health record, or the EHR. So you can see what's happened. You can see what medication this patient has been taking over time, and for how long. And we can also see, if you look down at the bottom, the different evolutionary reports on the different analyses and the blood work that has been asked for this patient. Now, we can also expand the timelines. You can look at it over the last year, or even more, or just a few months. And you can actually look at it day by day as well. You can choose the time frame that you want to look at. And this, again, reflects all the information which is included in the EHR. Here we can see, this is an example. There's been information about the medication that's been prescribed, has been added there. And then down here, this is a GP who has incorporated this extra information into the patient's ebook, into the patient's timeline. Now, what we're saying here, this is a daily charting of this patient. We can see that they were admitted to A&E. Why? And we can also see that they were admitted to hospital directly from the A&E department. And you can add another line as well, which is represented graphically here to tell us what actually happened, and all seen from the patient's point of view. So throughout the entire care process, you can see that X-rays have been asked for, different blood work, different analyses. And all of this information is available. It's on the timeline, so you know exactly when it happened. You can actually get to it straight from the timeline, and you can actually see the results of the scans or the tests or the X-rays or the results of the blood work directly from that timeline. And we're not just incorporating free text language. We can add other information, scales, etc. That all that needs to be structured. And we can do that through forms or questionnaires. And all of this is included in the EHR, the electronic health record. There's different types of forms or questionnaires, different scales. Others has to do with follow-up, the results of the different tests or the blood work, for example. We can look at them, or we can information about therapeutic positioning, indication, screening, etc. All of this is structured information. With regard to e-prescriptions, since 2010, which was when the whole EHR program was rolled out, we started to work with e-prescriptions as well. So it's all the way from when the prescription is actually written to when the medication is given to the patient at the different chemists or the pharmacies. So we have a single pharmacotherapeutic history is what's generated. So we know exactly what's been prescribed, which medications have been picked up by the patient, either in the pharmacies or in the hospital. So all the medication is included there in a global way. We also have a specific section in the EHR, which tells you what medication has been picked up by patients, either in the high street chemist or in the hospital. And then we share. This tool is shared by clinicians, pharmacists as well. All this information is available to all professionals involved in the process. Recently, we've added another possibility. You can access this through tablets. The administration of the medication can be accessed through tablets. So a patient who has been identified through a bracelet, as you can see in the image at the bottom, we can just scan it and immediately we'll be able to see on our tablets what medication they have been prescribed. And we can do this at the side of the bed. We can know exactly what's happened. We know exactly what medication has been administered to the patient, what's been prescribed, etc. So we know what we have to do. With regard to inpatient prescriptions, we can see that any clinician, primary care, anyone can actually have access to this electronic health record. And this enables us to come up with a single pharmacotherapeutic plan for the patient, which takes into account all the different services that are caring for them. So the prescription, when it finally arrives to the different chemists or pharmacies in the Basque country, the patient can then go there and then just pick up whatever medication they are due to pick up. This is at the moment, it is integrated with the rest of the prescription system in Spain. So even if a Basque patient travels outside the Basque country, they can still pick up their prescription, and their information about their medication will be available in all chemists throughout Spain. And this enables us to compile a pharmacotherapeutic plan, which can be printed out and given to the patient, and is also available within their electronic health records. In pharmacies, when patients go to pick up their medication, this information, the fact that they've picked it up, is returned, is included in the EHR. So we know whether the medication has been picked up, whether it's been dispensed. And we can see different periods in which the patient hasn't picked up their medication. We see that very clearly. And so we know exactly what's going on with the medication that has been prescribed by the different clinicians working with the patient. So to complete the pharmacological circuit, if you like, we've also developed a specific app, which is called My Treatment, Mi Tratamiento, which is connected to the electronic prescription, the e-prescription, so that if any of the treatments are adjusted, then that's the patient is told of that, they're told of the modification, they're advised of it, and the patient can manage their own warnings. They can also communicate through the app with the clinicians if they have any doubts or questions that they need answering. And just to finish, because we're going to be looking at non-face-to-face consultations now. For us, it was an important change some years ago, although it seems fairly normal now, but at the time, 10 years ago, it wasn't quite normal. And that was the ability to actually incorporate non-face-to-face consultations. So that they only go in person when it's actually necessary. And to do that, we incorporated different types of face-to-face consultations, for example, telephone consultations, which before the pandemic in primary care actually accounted for 25% of consultations and is combined with face-to-face consultations. And one of the problems that we're seeing now with the pandemic is that before, what seemed to be very complex non-face-to-face consultations, well, actually now it's just run-of-the-mill. It's what we have to do. Whereas the ideal situation would be a combination of both of them. So patients don't have to travel if it's not necessary, but we still need to have face-to-face consultations because sometimes they're necessary. Another type of non-face-to-face consultation that we have is virtual consultation, which Igor is going to be talking about, telemedicine, telemonitoring as well. We do this with chronic patients, for example. And the patient diary. So patients record different pieces of information every single day from home, and then that gets sent to their doctor. And then we get warnings or messages as clinicians if there's an alert, for example. And then we get in touch with the patient in order to confirm the veracity of the alert and to try to take the steps to solve the problem, or if anything needs to be modified in the therapeutic plan, etc. Non-face-to-face consultations are really becoming very, very popular, because if we're talking about integration obviously means that we have to work as a team. And so if you have a doubt in your service, on your particular specialist area, or if you want to consult a colleague at a different service or in a different hospital, for example, we can do that now. Using these non-face-to-face consultations, because any professional can in fact manage and set up this consultation without actually having to send the patient off to the back of beyond to where that particular specialist is working, for example. So the professional who is actually going to be carrying out the consultation and to answer any doubts that might have occurred, or they can ask for the tests or the blood work that they need to complete their study. But this information is shared with the patient and with their primary clinician, so that there's a kind of a team-like decision that is made. Another important element, what is increasingly important, is accessibility. It's important to make sure that this information is available on the move, both for clinicians and for patients as well. We need a greater degree of mobility so that we don't actually have to be sitting down at our desks with our desktop computer. We need to be able to access this information on the move, and also patients need to be able to do that from home. So we believe that connection with patients is fundamental. This can't be something that is isolated or that's generated independently from the health record. It all needs to be integrated. And everything needs to be registered in the electronic health record, so it has all the information is there. So we know, we can guarantee that wherever the patient requires medical care, the information, the latest information is available immediately. And if there's a discrepancy, for example, we can explain, we can see what it is and explain to the patient very, very clearly what needs to change so that they can understand what's going on much better. Within all these areas, we have different areas. We have the asking for a doctor's appointment. Also, we have health tips. We have our health folder, which will be you'll hear about a little bit later. I think Antonio is going to explain that. Thank you very much. That's my presentation. And really, just to sum up, what is it that is telling you what we've done, why we've done it, what the situation is at the moment. Because all these changes, what they're enabling us to do is to increase or to measure better what we're doing, the efficacy of what we're doing. And this means that the therapeutic plans are much better because they are worked on as part of a team involving different clinicians and also the patients themselves. Thank you very much.
Thank you very much, Mika, for this. Yeah, go ahead, Nessa. I wasn't sure if you were still here or not.
No, I'm here. It's just I've got some really loud drilling going on right outside my window now. That doesn't help. I was just going to check if we're going to hand over straight away to Antonio, and then also ask people if we wanted to have just a 5-minute break after Antonio's presentation. What do you think, Irati? Is that okay? Or do people want to go straight through?
Yes, it will be okay.
Okay.
5 minutes
Andre?
of
Bien,
yep.
una pausa estaría bien.
Fine.
Sí.
Okay, Andrea,
Yes, a
is that
5-minute
okay?
break would be all right.
Okay.
Yeah, that's perfectly fine with me. Yeah, let's have one more presentation and then a short
Okay.
break. We'll continue.
So Antonio, over to you.
Muy bien. Buenos días. Soy Antonio de Blas.
Thank you very much. Good morning. My name is Antonio de Blas from Osakidetza, and the previous speaker, Mikel Ogueta, and myself work at the General Directorate of Osakidetza in an integrated way. As you will see, we're going to be mentioning sometimes in our presentations, we're going to be mentioning the same tools. The main word and term that can summarize this whole system is integration, and that's something I'm going to be saying over and over again in my presentation. So the new information and communication technologies, ICT, are very widely used at all levels of our society. We use them every day with our family, friends, with our bank, and this is why Osakidetza has also included them in our daily activity. We believe that this integration provides a better, more accessible service to patients. We can improve our quality and the quality of our systems and services, I mean. And here, let me mention the integration of different care levels, for instance, primary care and hospital care. And then it makes possible a collaboration and partnership among different clinicians that treat one same patient. And with that information they get, they can patients can also manage their own health. And so it has great advantages to it. Our system is called OSAREAN. This is the system we have for non-face-to-face care. And here we have telemedicine, apps, etc., etc. I'm going to be mentioning these tools later on, and I will be concentrating mainly on one of them, which is a health folder that we use every day at all times. One thing I would like to highlight, first of all, is that all these tools that the Osarian strategy is using are also integrated in other systems covering the electronic health record, as Mikel just told you. And this provides additional value. We don't have tools that are autonomous, but we rather want tools that are integrated in a number of different systems. And this is what you can see on the slide. The whole system is focused on the person, on the individual, and then around that individual you will see a number of different tools like OSAREAN, etc., etc. And these tools are used by the professionals that look after that individual. So the whole system is integrated and includes all of the tools that also interact between them. So the health folder I just mentioned to you is a digital platform, a tool that we have in Osakidetza. It's available for people over 16 years of age, so that they can have access to their clinical health record. They can access that information 24/7. Of course, from everywhere around the globe. And this is important because due to the pandemic, now we're traveling less, but when we go back to the previous situation, we'll be traveling a lot, I guess. And sometimes you can have a health problem while you are in a different country and you need care. You need healthcare. And for that, you may need to provide information about you and about your health record, so that the clinicians that are going to be looking after you can know what has been going on. And so patients can have access to their health record from any device and from anywhere. This health folder covers 4 main areas. One of them would be the area where we can see and download information, because we can actually download a PDF file with this information. The second area would be an area where we can provide information, so patients can add information to their health record, maybe some tests that they have run elsewhere, maybe in private hospitals, so that they are available in this electronic health record. Of course, that needs to be validated by a professional clinician. Sometimes some of these tests or reports are very useful, actually. Patients can also provide information about symptoms they may have, etc., etc. And the third area here would enable interaction. So there can be a communication between clinicians and patients here. We'll see about that later on. And then the fourth area would be third parties having access to the folder, of course, whenever they have the legal permission to do so, because there may be, I don't know, it could be parents of minors, etc., etc., or there could be many different and special situations there. So let's have a look at each one of these areas. What's the information we can get on the folder? Well, we can have information about almost everything, all medical reports. You can get personal information about the patient, address, telephone, email address. You can update this information as well. If anything needs to be modified, it can be edited here, and it will automatically be included in this electronic health record. You can also have a look at all types of reports concerning surgery, radiology, analysis, tests. All types of reports will be available here. The pharmacological treatment can also be checked here. And if a clinician carries out a modification here, it is automatically included in this electronic health record, and you can also print it out if you need to have it at hand. We can also have a look at the vaccination history, so that you can also download that. Patients can have a look at their appointments, and you can download whatever you need on your smartphone directly. And you can also, if you are waiting for surgery, if you're on a waiting list, then you can check about your status. And you can know if you already have a surgery scheduled. The only thing that you cannot see here is the evolution, which is the notes that clinicians make in their contact with patients in order to register their evolution. That information is more targeted for clinicians and professionals, and not so much for patients. And on the second area, we can also add information to our EHR, any reports, any tests we've had from other services or other hospitals. Also information if you are part of a follow-up program. You can add any information concerning symptoms, vital signs, anything. And there you can have your diary. Patients can include the information about how they feel, how they're reacting to a treatment, etc. All this information will be available for professionals, for clinicians that are looking after that patient. Then we have a number of different tools that enable interaction. There's 3 of them mainly. Some of them will be unidirectional, like for instance a diary. Patients' diaries are only registered by patients themselves, of course, and every day they can write down anything they may find useful concerning their vital signs or their reactions to a treatment. Of course, patients are aware of the fact that they're not getting any answer to that, but well, the information on how they feel will be available for clinicians there. The next tool we have would be messages to the patient. This one is also unidirectional, but it is in this case the clinician who is sending out information to patients, which could be the outcome of a test or recommendation about a treatment, etc., etc. It's also messages that do not require any response from or reaction from patients, and it's information that patients can have a look at so that they don't have to get an appointment just for that. And the third tool I would like to mention here, it's called Doubts with My Doctor. Well, this is a bi-directional tool where patients can ask questions or doubts, share doubts with their clinicians, and then clinicians answer to them in a safe and confidential way. And this is, of course, very interactive. Patients can also upload pictures, for instance. And in order to be able to use these tools, you need to authorize your clinician. It's not an open tool. It's just available for patients in special situations. In case of palliative care, for instance, or in cases where the patients themselves need a very close follow-up by clinicians. And then let's have a look at the different authorizations concerning third parties that can have access to all this. The folder is available for people over 16 years of age, which is the legal age where an individual can have a digital signature, which is necessary in order to access the folder. So we had demands from families concerning information they wanted to get about minor children. And this is why we created this tool, so that parents or tutors of the patients can access information about them. It could also be the case of people that don't have any legal permission or capacity, but that for a number of reasons may have difficulties in using IT tools and who want someone else in their family to be able to access that information. And this is the case for the elderly, for instance, that need that information because they have many appointments so that their relatives can have the permission to access that information, and therefore they get that information faster and easier. As for the use of the folder, I told you earlier on that it's used endlessly. There's a population of 2 million in the Basque Country, and last year there were 1,300,000 entries. Since 2013, when we set up this folder, you see that the evolution's been upward. And precisely now that we're going through this situation of a pandemic, we see that all these tools, or all these digital tools, are highly used both by clinicians and patients. As for the profile of the people that are using these tools, you have the information there. More women than men use this, and their age range would be between 40 and 60. There's a number of differences between different healthcare areas in Osakidetza, as you can see there. and that's the rate per 1,000 inhabitants. And you see there are differences in the different geographical areas. Within our OSAREN strategy, we also have another important tool, which we call the Health Council. Well, it is a platform run by nurses that works 24/7 as well. And it works mainly when health centers are closed, because health centers normally work from 8 to 4 or 5 p.m. from Monday to Friday. And over the weekends, patients have the possibility to call this or to make use of this health advisory tool. Now we see here. Its two main functions would be to answer the calls, phone calls made by patients and phone consultations in a custom-made way, of course, because the people in this service can have a look at the electronic health record of the patient and can provide a custom-made response, of course, adapted to that patient's situation. They can also make an appointment if necessary, or send out health resource like an ambulance if needed, or they can also refer the patient to a different service. The total number of calls received last year was 359,000. 80% of them were solved or got a solution, and the rest was referred to other systems or departments. This health advisory tool also provide follow-up processes to patients that are frail, that are participating in specific programs, that have palliative care, that are in home hospitalization. And so they call them frequently in order to know how they feel. There is a group of people that made 41,000 calls last year, which are patients that live on their own at home and have this alarm button at home that they can press whenever they need care. And this system also provides direct communication with the health advisory tool. We also provide phone consultations because the phone is still a widely used tool. In 2020, 5.5 million consultations were made over the phone, and this is only covering general practitioners. Of course, the pandemic has made use of this system or has pushed us to make use of the system. If you look at the number of calls made concerning pediatrics, they amount to 680,000. Well, another tool for making appointments here, what we call web appointment, will enable patients to precisely that, make an appointment. We also have an automatic telephone service that enables patients to get an appointment 24/7 over the phone, and the advantage being that you don't have to stick to the opening hours of the health centers, of course, to make an appointment. Then we also have telemonitoring programs that are more and more widely used. These programs enable patients to stay at home, because normally it's frail patients that we're covering here. And these patients can make use of specific devices that will help them send us information about their vital signs, etc., etc. So all these patients are visited by a nurse every day, but virtually in this case. So that person will have a look at the patients, and if there's anything strange going on, they get in touch with that patient or their relatives, so that maybe the treatment can be adjusted, or if they need a new appointment with a doctor. So on the one hand, we reduce the problems that patients have, and on the other hand, we're going to be reducing the number of patients that are hospitalized. So now we've got problems with patients, we've got programs like tele-monitoring I told you about, with the patients that have COPD, or people that have Holter sensors, defibrillators, etc., etc. We believe that these programs are going to be more and more widely used in the future, because of the aging of the population, and I believe they're going to be very useful. Of course, not all patients will be able to make use of telemonitoring services, but if they are hospitalized over and over, they may make good use of this follow-up system.
Another important area, or another type of tool that's very important, are the apps. We have lots of different apps which have been developed by Osakidetza, the Basque Health Service. Mikel has mentioned some of them as well. These apps can be downloaded for free by patients, and they can download the one that they feel is most appropriate to them. There's one called My Treatment. Mi Tratamiento is what it's called there. There are people who take 8, maybe 9 different types of medicine every single day. And this app is directly collected up to their health record, and it's updated as soon as any clinician modifies their health record, and the patient can configure the app and then set it so that alarms will go off when they need to take medication, and they need to say whether they've taken it or not, and they get told if they haven't taken what they should be taking, etc. There are other apps as well. For example, we have the Osasun Escola, which is the health school. This is a platform to help train chronic patients to improve their self-care. We also have a list of professionals who want to work in the Basque Health Service, and they can put their name up on there if a position becomes open. There's also information about defibrillators, or where the nearest defibrillator is in the case of an emergency. And you can also have your health folder and access to your health folder over your mobile phone. There's also another app which has just been designed recently, which follows or aims to monitor child obesity. It's been designed in accordance with the principles of serious games, and it helps the child, him or herself, and their families to change habits which are very difficult to change, because eating habits aren't easy to change, but it helps them to fight against obesity, especially child obesity. So this is more or less a summary of the different tools that we have set up, and I'd be delighted to answer any questions that you might have at the end of the presentations.
Thank you, Antonio. Thank you. Very comprehensive, 2 excellent presentations. Andrea, just to double check, we are going to have a 5-minute break now before we come back for our final presentation, which will be from Igor, and for discussion and picking up the questions. That okay?
Muy bien.
Yeah,
Okay,
that's fine.
everybody.
Perfect.
It's almost 10:05. So I'll see you all back at 10 minutes past 10. Thank you very much. Okay, Andrea, just checking if you're back.
Yeah, I'm here.
It's just 10 past. Have we got everybody back? The only way to know that is, of course, if people put their cameras on.
Hello.
Sí, estamos ya.
Yeah, we're all here.
We're going to hand over next to Igor, who is filling in for Ruben, who is unfortunately unable to join us this morning. So Igor, if you wish to share your screen.
Okay.
Oh, Fritz's camera. Apologies, Fritz. Let me see if I could do anything. And
Check it here. Can you see it now?
yep.
Sí, yo sí lo veo.
Perfecto.
Okay, brilliant.
Okay,
Bueno,
so I'll just hand over and switch off my camera again.
Vale. Hola, hola a todos. Bueno, también
Hello.
hola Rubén.
Hello, Ruben. I know you're there. I think you might be watching the session at least. And in fact, it's Ruben who's designed this entire presentation, but I'm going to be giving it. But he's there in the background, he's backstage. So if I miss something out or I say something wrong, I'm sure he'll be able to correct me or fill in any missing information in the chat or in the Q&A session that we're going to have at the end. My name is Igor Zavala, and I am head of care and chronic care integration here in Osakidetza, the Basque Health Service. And sometimes, as we say in English, I am a bit of a jack of all trades, but I am indeed a master of none. So I know a little bit about lots of things, but probably not a lot about anything in particular. But I will do the best I can. Let's see if we can get the presentation working at least. Okay, this is the index, this is the contents, this is what I'm going to be covering. I'm going to talk about the origin of the need, then I'm going to be talking about our diagnosis or analysis of the situation, the different types of video consultations that we offer at the moment in Osakidetza, the Basque Health Service, the designs that we're piloting or designing at the moment, and then the next steps. With regard to the origin of the need, I mean, where did the need stem from? I think COVID-19 and the pandemic has really forced everyone really to look for alternatives. It's more difficult to have face-to-face consultations with patients, and then over and above the telephone, something else was needed. There needed to be some other kind of intermediary service in order to ensure the quality of the service provided. Now, that was one thing, but another aspect to take into account was the fact that we were already doing this before the outbreak of the pandemic. This isn't new. This isn't just a result of the pandemic. Each different service or different health services were trying out different alternatives with different tools. And we also held a series of very inspiring meetings with our colleagues in Scotland, who were really very, very far ahead of us with regard to teleconsultations and video consultations, and that's really motivated us a lot to continue along this path. Now, what can it be used for? What needs can it cover? Well, it's up there on the screen. Non-face-to-face consultations with image or group sessions as well between different clinicians and patients. In our case, we have active patient or expert patients program, and we're doing that with group sessions, and then clinical sessions, and then general clinical sessions as well, and training sessions as well. One of the first issues, or one of the first things that we started to think about was to what extent should these platforms be integrated into our information systems? because we can use separate systems, systems that are separate from the electronic health records, or we could integrate it. There were two options. We decided that interoperability and integration will be a key element in this. So we are working towards integrating video consultations, integrating them into the electronic health records. And who are the stakeholders? Who are the people involved, or the actors, as we call them? Primary care, as you would imagine. We also have hospital care, both medical and nursing, and the administrative side of things as well. And of course, the patient. And also carers need to be involved as well. But all of this is gradual.
En ese sentido, los circuitos serían la atención primaria para con el paciente, también la atención hospitalaria y el paciente.
So we need to define the care pathways, and we have different care pathways. We have primary patient, hospital patient, and primary patient and hospital all working together for the good of the patient. When we're talking about interoperability, in addition to other systems, we also see, or we've found that Zoom is the tool that is perhaps best suited to being integrated with the electronic health records and everything that is already there in place. So it's a good way of managing the different requests that come out of the different circuits, as you can see up on the screen. Now, there's another issue that comes up time and time again, and we're still working on it, and that has to do with informed consent. Where is it included? How should it be included, etc.? So that's something we're still working on. And then another major issue is data protection and the role of the data protection officer. This is proving a little bit difficult because we have to guarantee that all of this data, this information, which is quite sensitive information, needs to be protected. This information needs to be protected within the system. So now, if we look at the different types that we have, or we will have from now on, and we'll be continuing to work on in the future, are the ones that you can see listed up there on the screen. We have one type of video consultation, which is organized at the request of the healthcare professional. That's probably the most common one. Also, at the patient's request as well. There's also increasing demand for home hospitalization, and then on-the-spot video consultations, spontaneous consultations, if you like, and then also it can be used to organize webinars and also multidisciplinary video consultations as well. This is another possibility of the general tool. What we do have clear in our minds at the moment is that the first consultation needs to be face-to-face. The very first contact between the patient and the clinician needs to be face-to-face. It's very difficult to actually do that and get the information that is required if we use a video consultation for the very first appointment. But if the patient prefers a video consultation, then they need to make sure that the patient understands what it is. And then a report will be issued through the electronic health records, in which we will explain what all the different technical, functional, and legal requirements are in order to make sure that it's carried out correctly. And if also we need to know whether the patient is going to come to the appointment by themselves or if they're going to be accompanied by a family member or a carer. That's also important to know. So the professional will then request a video consultation appointment in the diary, and the data will be collected. We will need the telephone number of the patient so that we can send an SMS, or their email address so that we can send them an email in order to set up the appointment. as soon as the appointment is made, then patient will be sent an invitation, either through SMS or over the email. On the day of the appointment, the patient will access their video consultation through the link that they will have been sent, they will have received on their mobile phone or their tablet or their computer, and the clinician will go to the appointment through the electronic health records. So that will be their point of access. That's the circuit that we have designed at the moment. Our idea was to start the pilot project next week, but for a number of different reasons, we're going to have to delay it for a further fortnight. At this moment in time, we have a series of professionals or clinicians who have expressed an interest in participating in the pilot project. And to our surprise, in fact, as soon as we invited them to participate in the pilot project, in fact, in less than 24 hours, all the people who were invited sent their reply saying, yes, please, in a very, very short space of time. So I think this is really indicative of the fact that clinicians are very interested in starting this whole idea of having video consultations. What do we need to take into account? Well, legal notices and legal aspects. This is really something that we need to work on. We've mentioned this before. And there's also another issue which has to do with recording. So should these consultations be recorded? Can they be recorded? At the moment, we're not going to record them. In the future, we might think about it again and reconsider this decision, and they might be recorded, or at least part of the session may be recorded. But at the moment, they won't be recorded. And if we do decide to record them, then we will have to come up with some kind of consent protocol, which will have to be signed by the patient. It's important that both clinicians and patients have a certain degree of information, certain degree of training, so that they understand how the system is going to work. And there are three different sections that we believe need to be taken into account in this sense. We have to give everybody involved the pertinent technical explanations. Now, Ruben understands these technical aspects much more than me, but you have technical explanations. And we also have functional explanations. So, for example, where should they be when they're actually involved in the video consultation? I mean, not in the middle of a busy bar, for example. They need to find a quiet place, good lighting, no external noise, background noise, etc. And then legal explanations. People need to know what's going to happen to all the information that's going to be exchanged with their clinician over the internet. To make all of this easier, we're going to come up, or we're going to design different guides to make all this easier and to explain this very clearly to both the clinician and the patient. The professional will be asked to complete a short questionnaire to make sure, or to determine whether the patient is actually a good candidate for video consultation. There will be different reports within the electronic health records that the clinician can in fact send to the patient. Within the electronic health records, in the appointment manager, there will be different functions there. And then there'll be informed consent. Now, this is an example of some of the videos that we're actually recording to help people understand how they have to act or what needs to be done. Well, this is particularly targeted at the healthcare professionals. Here we explain the advantages of the system, with what patients it can be used, what would be the situations in which it wouldn't really be advisable to use these kinds of systems. With regard to the contract with Zoom and the licenses that we will need, in this case, Zoom provides Osakidetza, the Basque Health Service, with its own facility. We have a universal license for all Osakidetza healthcare professionals. The license type is business professional. The number of people that can be in any one meeting is 200. That's the limit. And we can also actually have video conferencing. We'll have video conference with all of these people at the same time. Just to give you an idea of our timeline and what we're planning to do in the near future, sort of as a quick look at our roadmap, if you like. Here you can see that we're going to be developing different versions over the coming months. And in fact, that's going to take us up until June of this year. Now, from my perspective and where I work at least, often we think that when we're developing these versions and developing these tools and integrating them and then making them interoperable and then make sure that they integrate into the electronic health records, we tend to think that it's actually quite simple and it's just a case of, tying a few knots in here and there, but it's not. It's actually very difficult. Often we don't actually understand how complex the whole thing is. This is why it takes so long sometimes. So this is what we're hopefully going to be doing. We're going to start working with patients from March onwards, and with this pilot project involving 20 clinicians, hopefully we're going to be gathering information that will enable us to determine what needs are going to be arising, what needs still need to be covered, both amongst clinicians and healthcare professionals and patients themselves, because I'm sure there'll be a lot of fear, a lot of worry, what's going to happen to my information, where's it going to go? So we will have to develop and compile the guides that I talked about before, which will explain the advantages of this new system as we see what problems arise. So we also wanted to share a very short video. Let's see if it works. I hope it will. I wanted to show you a short video. I'm just going to go out and come back in again and see if you can see the video so you can get an idea of what a video consultation would actually be like. I'm going to try. If it works, great. And if it doesn't, well, I'll put the link up there. I was going to say tough cookies, but that's not what he said.
We have finally Ruben Lastra joining us, and maybe we can ask him if there's anything he would like to add to everything you just mentioned. I can't see him now. Let me just play the video. I don't know if you can see it.
Yes.
Fine.
Dr. Gorman. Hi, I've never really done the online doctor thing before. No, not to worry. It's exactly like a normal doctor's. No differences whatsoever. Really? So, what seems to be the problem? Yeah, I found something down there. Okay, well, we just take a little look, will we? Okay. All right, so just hop up on the bed there behind you and slip down the trousers, okay? Quick as you can, Paul. Okay. Right, so, any plans for the long weekend, eh? What? Just cough for me there? No, I don't feel anything. You're in the clear. So if there isn't anything else? Well, perfect. Okay, Paul. Okay, Jerry, you tell me you have a rash.
Yeah, on my arm.
Oh, can I have a little look there?
Okay. There. Do you see that there?
Okay, now with the texture, Jerry, would you describe it as medium rough or mild coarse?
Oh, I don't know.
Okay, I need you to be exact, Jerry, okay? Medium rough or mild coarse?
I'm not really sure.
Just take a breath, Jerry. This is very, very important, okay?
Mild course.
Oh, that is a relief. I tell you, if that had been medium rough, would have been straight to the emergency room. Well, look, if anything else crops up, you just let me know, okay? Bang me on an email.
Because I'm not really sure.
Now, Jim, what seems to be the problem?
I think I need glasses.
Okay, well, we'll check that out now. If you wouldn't mind, please, just reading this chart.
But it's all out of focus.
All of it?
Yeah, even you're fuzzy.
Oh, goodness, now, Jim, that doesn't sound good. That's very bad.
Yeah, I know you're back in focus now.
So I'm coming in and out of focus?
Yeah.
Okay, this could be serious.
I'm definitely still feeling something there, so is there maybe another way you could check?
There is another method. It's much simpler, actually.
Great, yeah.
Okay, if you could just pee into this cup.
Sorry, I can't.
Yeah. You need some privacy. I'll leave the cup here. I'll be back in a minute. Hello again, Jim. So we got the test results, okay? Are you sitting down?
Yes.
Okay, well, it's very serious.
Sorry.
43%
So
fatality.
you cut out there.
Extremely careful. Instant death.
I didn't get that. Hello?
These
I'm not getting that now. Sorry.
I will say it one.
It's very bad line.
Okay, have you got that?
The line is very bad now.
Good man. You'll be fine.
Lester, we're coming to you.
Ok, esta era un poco la...
Well, that was it. That's my presentation. So this is what we don't want to do, right? We don't want video consultation to be like that. So Ruben, is there anything you would like to add? Hello, good morning. Can you hear me? Well, let me first of all apologize for not having made my presentation. I'm sure that Igor did a wonderful job, but in this situation, well, of pandemic, I have to stay at home because both my wife and my son have tested positive. My daughter and myself are not positive, luckily, but well, we have to stay at home. So that's the reason why I didn't do my presentation. As for video consultation, we've thought about including this function in the OptiMedis system, and the pandemic has pushed us to do so faster than we expected. In November, we held some meetings. I am part of the IT division of OptiMedis, and we had some meetings with the management in order to think about this possibility. In November, we started collecting all the requirements, and now in February, we have sorted out the technical side of things, and now we can go for a concept test with clinicians. We have chosen both clinicians and nurses from primary care and hospitals, and we're looking forward to getting their feedback. And the idea is that we will later on improve what we've got. This first part of the concept includes a video conference between a clinician and a patient, but then later on there will be other uses where we could have maybe a number of different professionals or clinicians with one patient, or clinicians that cover home hospitalizations that may not necessarily have to go and visit their patients at home. So there could be a number of different uses, maybe some, I don't know, it could be some childbirth lessons or prenatal lessons, or that type of training that we could do and provide using this tool. We can avoid people moving from one place to another. That could save time, and This is why we believe this system can be very positive. We're going to be launching it very soon. In this first part of the system, which would be the video consultation, and then we will move on.
Okay, everybody, if we want to move into the last part, please. So we have reflections and questions from OptiMedis. Sophie, I don't know if you want me to read out the question you had kindly added to the chat earlier. I know it's a bit of scrolling backwards and forwards to find the question, but I have a note if you want me to just go ahead and recap.
I'm happy to just elaborate right now.
Okay.
So thank you, first of all, for the presentation. The digital system in Basque Country is definitely very impressive. And I can see particularly the value of it during these times. I have some questions regarding the implementation and utilization of the system that you've just described. But I will start with the utilization aspects. So I can see that, so as it's presented, the system can be fully utilized by both the providers and the patients. And I'm wondering, from the patient's perspective, have you guys had the opportunity to track the usage by the patients? So for example, what demographic segments that are most frequently using the various apps and I can't remember what it's called anymore, but the patient in the second presentation, the personal health folder, there you go. So if there's particular demographic groups and if there are particular sections, so introduced 3 different, the patient diary, I think, and other prescription aspects. Are there particular sections that the patients find most useful and use more frequently than the other sections? And are there other sections that have retired due to lack of use and engagement with patients? So I'll start off with those 3.
Sí, sí, te contesto.
Yes, well, thank you for your question. I guess you're talking about the health folder, because that's where the patient's diary is. So that health folder is very widely used, and every year we see an increase in the use of that tool by patients. And we believe this is so because there's high confidentiality rate provided there, because there's this data protection law we need to abide by, of course. So we're very highly sensitive to this. And this is why accessing is not that simple. We have a whole series of requirements that need to be fulfilled, like digital signature, etc., etc. But in spite of this situation, we believed we needed to provide patients with an easy access. That's normally the bottleneck. The access cannot be very hard, very difficult, because if that's the case, people will not access the tool. So we, at our health service, we manage some passwords that are used in order to access this health record. We had in the past a password, and then this board game of coordinates that was individual. So they needed to provide 3 different coordinates from that card, right? Very recently, we've introduced a system that is simpler, which is based on the OTP European system, and which requires a password from patients that then get a key, a code on their smartphones that varies and changes every time you have access. And this enables us to get rid of that card we used in the past. So we're trying to simplify things as much as possible. for people to be able to access the electronic health record. Of course, individuals that have digital DNA can have access very easily, and for that you need a reader, right? And that's not very widely used, and this is why we didn't go for that solution. This is why we've chosen this second possibility that requires a digital signature. And as I said, we're now recently implementing this OTP system where patients get a code. Yes, I gave you my presentation some data about utilization. As I said, women use this system more than men. And then people between 40 and 60 years of age seems to be using this tool more. But of course, there are people above 60 and below 40 that are using the tool. Of course, below 40, in some cases, they don't have much information in the health record because they're quite young yet. And the group of people above 60 years of age, well, seems to be using IT tools very well. So we need to get rid of this preconceived idea of older people not being able to access digital tools and devices, right? But they're now more and more used to digital tools. And, well, older people use these tools in a very normal way. As for the type of information they look at, well, of course, they look at the pending appointments or maybe the results of tests that they still have to get. That's the type of use that we observe. And then another tool we provide would be what we call the health advice tool. And that's very useful. It's easily accessible. You can call anytime and you get a clinician answering, a person that is professional, that can look at your health record, that will make a recommendation that is custom made for you and for your situation. You can even say, oh, I forgot how I have to take my medication. Some people just forget. Oh, what did my doctor say? And well, it's imagine it's a Sunday and it's 10 p.m. Well, you can simply call and this professional will have a look at your health record and your treatment and will provide you the necessary advice. This is useful for people that are not so much used to IT tools, right? And as for apps, and other tools we provide are targeted at more specific groups of people. We want to foster the use of my treatment app, in order to remind patients that they need to take their medication. There are a number of different apps like this one, but which are called something like Pillbox, for instance. But here in our tool, we provide custom-made information. If you're a patient and you're having many pills a day, then you are going to get customized information because any modification, any change is automatically updated. And so for people that take many pills a day, this is extremely useful. It is used by older people, therefore, and also by their carers and relatives. It is also true that the COVID pandemic has highlighted all these tools we have available, because in the past, some clinicians were very reluctant to using non-face-to-face tools. But now they've changed their mind, and it's key that they promote the use of these tools, digital tools, I mean. And I think that they can be very, very useful. We can, of course, launch campaigns and print out leaflets. But I believe that if clinicians suggest that that patients should use these tools, they'd be very useful. And I don't know if that answers your question, by the way.
Yes, that was perfect. Thank you. Some follow-up questions from the providers' perspectives in terms of their utilization. I am wondering, one second. So it's very interesting that, and really great that patients have, it seems like, full access to the EMR records. And I'm wondering, when this was first introduced, was there pushback from the physicians regarding this aspect, and how was that addressed and mitigated? And
Muchas reticencias.
They were
Yeah.
very reluctant, yes. And there's been discussion going on about this, because, for instance, the results of tests or blood tests or biopsies, I mean, what is the point when patients can have access to that, right? Because when we started, whenever the test was validated by the lab staff, at that very same minute, the patient could see it, right? Just at the same time as the clinician. And there was a discussion about that going on. And that led us to including a 7-day delay time where the patient cannot see the result of their test, but where the clinicians can actually have access to that. And some patients complain about this because they want to see that from day one. Well, this is the situation we have now, but you're right. The professionals were quite reluctant at first.
But of course, as it goes on, healthcare professionals do see that it's useful, because when patients go in and they look, they don't just come across their results by accident. They actually have to look for them, which means that they're interested in it. So we're talking here about patients who are very aware of their own health. So it's a certain type of patient that will actually find these results. So I think the pushback is getting less, it's getting weaker. But for example, for X-ray results and other results as well, there's a 7-day delay at the moment, so that the healthcare professional gets to see it first. And if there's something that you need to prepare the patient to see or to hear, for example, you've got time to do that. But there's still a lot of debate about it. Not everybody is of the same opinion. There is a debate. There's a bit of controversy about this at the moment. If I could just add to something that Antonio has said. The fact that the patients can see sensitive information is difficult, because sometimes this information needs to be explained properly to patients. But what we have seen over the last few years is that the systems are being reorganized as we go. So, for example, there are 7 days, the professional has 7 days in which to look at the information, see whether something needs to be done before the access will have access to it. So I think we shouldn't be worried about changing procedures. We need to change according to what we see is happening. Before, we saw in the clinical panel that I can see all the results of all the, for example, the different tests that I'm asking and I'm ordering for my patients. I can see all that information as a professional, so I can get into contact with my patients if I need to. In a consultation as well, in the electronic health record, we actually see how the patient's going to see the information as well. But in the folder and in all the different processes, I think that the digital advantage needs to be that we need to be able to set up new communication channels, and not everyone has to be involved in everything. I think that's a mistake. It's just another option. Not everybody needs to be there. Sometimes we develop different plans for different patients, and the same thing, there are different tools which are good for some patients and not for everyone. Or there are some situations in which it's simply not suitable to use these tools. So I think we need to have it clear in our minds what is the best type of communication for each particular case.
Thank you, Mikhail. Sophie, I just wanted to pick up another couple of questions in the chat,
sure.
just if we can come back. So some of these, I think, Mikel and Antonio, you've sort of answered already in some part, but just to make sure we cover them if we can, please. So we had a couple of points from Fritz, which were very welcome, about the video that you showed, Igor, and the pitfalls of poor communication and what we assume, we think we know about video consultation sometimes, and what people expect from video consultation. But I think also for me, it highlighted the importance of really that open and honest consultation where, you know, what do you get, what can you expect, how will it work, who is it for? And actually the point you just made, Mikel, about, you know, just because it's not for everybody doesn't mean it's not for anybody. So you need to consider the patient first and their requirements, and you know, what they can and can't do and what they do and don't need. So I thought that was really helpful. The video showed us a lot of that in a very funny way. But just coming back to the EHR, and Fritz had made the point about non-digital native people. So I think from this, you mean people who have not grown up using digital technology, are not very familiar with it. Some of this, Antonio, you answered, you made the point very well that we have to stop making assumptions about older people, especially. But people react to, how do people react to the comprehensive electronic health record system in the Basque Country? Do you offer face-to-face training, for example, to get people used to it and available and ready to use it? So I'm not sure if that's Antonio or Mikel wants to come in on that.
Sí. Sí, se ha hecho sobre todo al inicio.
Yes, especially at the beginning of the health folder, we did run training sessions through the local councils in the Basque Country. Also in, for example, clubs to which older people go, civic centers, we run different courses to tell them how to use, to teach them how to use these tools, how to access them, etc. We also often visit nursing homes or day centers or clubs to actually, you know, we go there to explain to them. And in fact, to our surprise, there are lots of people there who just go, yeah, no, we know all about this. We're doing it already. So I think we have to perhaps try not to be so paternalistic sometimes, because often they tell us how they're using it. And in fact, we get ideas from them. I mean, they know more about it than we do sometimes. So as I said before, GPs, they have a very important role to play in all of this. And they have an important role to play in fostering the use of these tools, because as Mikel said, in the health records, you can see, in fact, whether the patients go into their health folder. You know when they access it, you can see whether patients are using it or not. So you can see how apt the patient is. I mean, how efficient the communication channel is, and if they're not using it, we can perhaps promote it more or encourage them more. But everything we do is always too little. We always get the feeling that we should be doing more. I don't know, Mikel, if you want to add anything. Yes, I think that one of the things that we said right from the very beginning is that the tools need to be as similar as possible to what is already there, to the systems that were already being used by the patients and by clinicians. I mean, a mobile phone, everybody uses their mobile phone. But if you're going to actually be designing tools and you need to have to run a training session to explain to people how to use it, that means your tool is too complicated. It's not intuitive enough. So we needed to make them simple and easy to use. What happens is that we often carry out modifications and improvements and people don't realize that we've done them. But there are lots of updates that we don't use. And when you realize, oh, there's that update, there's this improvement. Oh, well, that's a much easier way of doing it, but you don't realize it's there. So I think the advantage, for example, with ebook, you can create a website. So we're basically using tools that are commonly used in other circumstances and in other fields, and that makes it much easier to implement. If you go to things that are too complicated, then that makes it more difficult. So if you're trying to change these systems, whenever we try to change these systems, a lot of fear is generated both among professionals and patients because you're changing the way that they're used to doing things. And it's the difficult thing to do. So I think it's important to have a long-term strategy, which we do here in Osakireta. We established an initial basis at the beginning based on experience, and then we change it depending on the results that that we find. For example, often clinicians used to spend more time copying everything onto their computers than actually talking to patients, and that was a mistake. That was something we wanted to avoid. So as a result of that, we have simple tools, which means that we don't have to duplicate everything, which is what we've always done in the past. You spent more time copying everything out, typing it into your computer, putting it here, putting it there. But of course, it's very easy to say we have to simplify things, but it's actually very difficult to change the way we do things. When we were talking about the implementation of the EHR, and we had to actually include the hospital pharmacies, this was very important. We had to use the e-prescription because they had to have a control over the medication. And it seems very simple, but it was difficult to actually make that step. And the fact that we can actually talk and it's recorded automatically. And we often relate it to age, but that's a mistake. There are older clinicians who are really interested in doing it, and then there are younger clinicians and patients as well who just see it as a bit of a pain. So I think that when you're implementing a digital system, the advantage really is only palpable if it's integrated into all the situation, in all the processes, and all processes need to be integrated and updated in accordance with this digital system. Because if we're just doing exactly the same as we were doing before, but doing it using a computer, that's not really, there's no advantage to that. So we need to make sure that it's actually going to improve our clinical practice. And we need to modify the circuits that we use, the processes we use, not just the tools or the techniques or the technology. So we need to really make the most of tools that are there in order to actually make interactions more effective and easier. Just one extra point, because this is something that Sophie mentioned and other people as well. And Ruben can perhaps confirm this. One of our obsessions when we're designing tools for patients is that it needs to be simple. From our side of things, it needs to be well integrated. That's like the major thing. That's the most important thing. It all needs to be integrated. But this is from the side of the professionals, the clinicians. But when we're actually designing things for patients, our overriding goal is that it needs to be simple, easy to use. Because sometimes these platforms have their own requirements, and these requirements can't be adapted. And often things get complicated. But as a user of the folder or the video consultation system, which is what's going to be rolled out very soon here, if I have a patient and I put that patient in the situation of having to choose between two colors, for example, without any more information, or for example, or if I give them a really complicated system, then things are going to go wrong. Things need to be really clear. Now, our aim with the pilot study that we're going to be carrying out very, very soon with the teleconsultation or the video consultation, we're going to ask clinicians to tell us what they find confusing so that we can sort that out for them. And patients are going to tell us what was difficult, what was hard for them, so that we can adapt it to their needs. This is the whole point of the pilot project, and simplicity is paramount. And then secondly, another thing that's important is that you need to create a narrative. And what does that narrative have to say? Well, technology tools isn't impersonal per se, that it's not an impersonal type of care, that behind these machines, there are real people who are caring about your health, who are going to make the best decision for you. And this is really important to convey this, because what some patients might feel or I might feel, if I go to different places on the internet, I don't really know where I am. I don't know where I'm going. And there is some kind of reluctance. There's a fear in me that I'm giving out my private information to people who I don't really know and I have no control over. So I think we need to really raise awareness among patients. We need to tell them and assure them and guarantee them that all their information will be protected by a public health system with all the same guarantees as the situation or the process in the past. Last year, we did carry out a small pilot project with chronic patients, patients with chronic diseases. So complex chronic patients is how we classify them. And this is what they said to us. They said, look, if I go in over the Zoom platform, my fear is that I'm giving really sensitive personal information and that might end up in the hands of some company who might be using it for who knows what purpose. So we need to create a narrative of the benefits, of the advantages, but also cautionary tales as well, so that people are careful with what they do. Well, this might seem a bit like Groundhog Day because I might be repeating myself a little bit. But when we started out with telephone consultations in the Basque Health Service or Osakidetza, this seems fairly simple, right? We've used the telephone all our lives, all of us. And it was just another way of being able to foster contact between the patient and the clinician. You can, when you are asking for an appointment, can actually ask for a telephone appointment. When we first started doing this, the clinicians were worried because they thought, oh no, people are just going to ring us for any old thing. And some patients thought, they're doing that because they don't want us to go there and annoy them so that we can leave them alone and leave them in peace, stop bugging them. And in fact, we've seen that there is greater access, consultations are more efficient, but of course at the beginning it wasn't seen like that. And now with the pandemic, when we actually started, well, with the pandemic, there was a problem because people actually had trouble going to see their doctor, and they certainly couldn't go with somebody else to see their doctor. And in fact, all of a sudden, oh, look, we can talk to them on the telephone, and I can do it from my work. And in fact, people changed the way they saw it. So I think that at this moment in time, and especially in the future, in the near future, starting to talk about video consultations, I think it will be received. I mean, we tried to do it a little while ago and people decided that it wasn't the right time. But it is important to get the time right to see when it's actually going to be received and people are ready for it. Because it is a very useful tool. It means I don't have to actually physically go somewhere, which at the present time is an advantage, but it will remain an advantage even after the pandemic. The key, I think, to all of this is to decide with which patients we're going to use which tools, because they're not all going to be adequate for everybody. And that's an important choice to make. And I think we all need to have it very clear in our minds, the fact that we have lots of different channels and that there's going to be different channels that are going to be suitable for different patients. And sometimes as a clinician, we might think, well, this is the easiest one for me. But in fact, we need to see it from the patient's point of view. They might see it as a problem. They might see it as a delay. So I think we need to see things from the patient point of view as well. We need to focus on the positives. We need to focus on the advantages. And in fact, the centers and the hospitals that are more advanced should be a role model for other people to follow. But we need to make sure we do it carefully. And we need to get good examples out there so that other people can be convinced that it is possible and it is advantageous.
Thank you, Michael. I'm just butting in now because we're a few minutes over our closing time and I know people have other commitments in their diaries. I just wanted to say thank you again to the experts who've joined us from the Basque Country. Really great to have the opportunity to have this group of people available to us to answer the questions because they know everything about the system and how it works. And thank you to our colleagues from OptiMedis for joining us as well for the engagement and the questions and the discussion. Hopefully that's been a really interesting session for people. The recording will be available in a couple of days, and we'll send you the link, obviously, so you can share that or listen back to different parts of it. And I'll check again to make sure we haven't missed any questions in the chat. I think we covered most of them, and it's been really informative. So Andrea, I'm just going to hand back to you if there's any final things you need to say.
Yeah, I just would like to really echo what you said, that it was extremely informative, and I hope that particularly our colleagues from OptiMedis found this session useful. And yeah, I would really like to encourage to review this webinar again and, like see if all the kind of like aspects and questions you had in OptiMedis were answered. And if there is, any, specific topics you would like to follow up and continue with this mutual exchange, because obviously today was a starting point for you to give a kind of like bigger picture how it looks like, and we have the opportunity to drill down into details as needed. So just, keep that in mind. But thank you so much for everyone for a great session.
Okay, well, I'll say cheerio then, and enjoy the rest of your day to everybody. Thanks again. Thank you. Bye.
Thank you.
Thank you. Bye-bye.
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 Eskerrik asko guztioi.
Eskerrik asko.
Thank you very much, everybody.